From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to this JAMA podcast. I'm Dr. Kirsten Bibbins-Domingo, and I'm the editor-in-chief of JAMA and the JAMA Network. I'm joined today by Dr. Lee, who is a family physician and the Walter M. Seward Professor and Chair of Family Medicine at the University of Virginia School of Medicine. He is also the Director of Population Health at UVA Health and the leader of the Cancer Prevention and Population Health Program at the UVA Comprehensive Cancer Center. Dr. Lee is a member of the U.S. Preventive Services Task Force and is joining us today to discuss the new recommendation from the task force on screening for lipid disorders in children and adolescents. JAMA is publishing this recommendation statement and the evidence report on which the task force recommendation is based. Dr. Lee, thank you for joining me today.
Thank you for inviting me to talk about this important topic today.
Wonderful. I hope you might begin by just giving us a summary of what the recommendation is from the task force. What is the task force recommending with regard to screening for lipid disorders in children and adolescents?
Definitely. So the task force found that there's insufficient evidence to assess the balance of benefits and harms of screening of lipid disorder in the general pediatric population for those who are 20 years or younger. And it's an I statement. It's not a recommendation for or against screening. Rather, it's a call for research.
So an I recommendation is one that the task force designates, and we always like to talk through what an I recommendation means. As you said, it's really a call to action for researchers to give us more evidence to help us to make the decision on screening. It's not a recommendation for or against screening, but really a call to action. So maybe you could talk us through what the evidence tells us right now, and so that we can understand where the gaps are.
Indeed, it's a call for research on this topic. So the task force reviewed up-to-date evidence and found insufficient evidence for us to assess the balance of benefits and harms. During the process, we have identified several research gaps that we call for more research. This includes 4 major points here. One is that we don't know the long-term benefits of screening and treatment of lipid disorder for the general pediatric population. That's number one. We need long-term data on the effectiveness of screening and treatment of lipid disorder among the general pediatric patients who are asymptomatic of any symptoms or diagnosis of lipid disorder. That's number one. Second, that we also need more evidence on the long-term effect or harms of treating lipid disorder for the general pediatric population. What's the long-term harm? We don't know that for sure at this point yet. And also, we don't know, although there's FDA recommendation for treat lipid disorder in young children starting at age 8, we do not know the optimal age of starting treatment of children or young adolescents. The fourth one is that we don't know how accurate or how good is the screening test to identify children or adolescents who are 20 years younger in the general population of lipid disorders. So those are 4 major research gaps that we have identified. Cutting across all these 4 research topics we identified, really we believe that, and we really advocate for all the research should include the group or the population who are disproportionately affected by lipid disorder or heart disease.
So you've outlined 4 important areas where we don't have enough evidence, but we do know, at least from the epidemiological evidence, that having lipid disorders in childhood is associated with the likelihood of having premature cardiovascular events when you're in young adulthood. Is that true?
So, as I mentioned, as we review the data, we do not have any evidence showing that screening in the general pediatric population translates into reduce or prevent premature cardiovascular event in adulthood. So that takes a very long period of time for follow-up, or your trial would take decades. Unfortunately, we don't have data at this point that directly showing that this benefit screen the general pediatric population when they're young, and this will translate into benefit in terms of preventing premature cardiovascular event In adulthood, we don't have that piece of information yet.
I see. So you're saying that even though we know that there's the association that if the lipids are disordered in children, that there's a risk of cardiovascular events later, what we don't know is whether doing screening asymptomatic children or adolescents helps us to actually change that risk that happens later on.
Exactly. So the link between adult hyperlipidemia and adulthood premature cardiovascular event or death has been well established. But what we're talking now here is screening the general pediatric population who are younger than 20 years old, no symptoms. If we do screen the general population, we're talking about general mass screening, whether that translates into benefits into adulthood, that's unknown at this point. It will take many years for follow-up, if you can imagine.
Hmm. So you focused in on really two types of lipid disorders, familial hypercholesterolemia and multifactorial dyslipidemia. How common are these types of conditions in childhood?
So indeed, the task force reviewed evidence for two conditions that impact children and young adolescents. The first one is familial hypercholesterolemia, which is a genetic disorder. It's basically caused by genetic defect that will cause very high LDL cholesterol early in life and which will translate into premature cardiovascular event in adulthood. So the prevalence, we focus on heterozygous FH. We didn't actually look at homozygous FH, which is very rare. So the heterozygous FH, it's about 0.2 to 0.4% in the general pediatric population. And the other one is a multifactorial dyslipidemia, which is much more common. It's associated with mainly environmental lifestyle. For example, people who have excess saturated fat intake, physical inactivity, obese, more likely to develop multifactorial dyslipidemia, and some very small but additive polygenic genetic variant may contribute to this as well. The prevalence for the latter is about 7 to 9% in the general pediatric population.
So you haven't focused on homozygous FH, which is rare. The conditions you're talking about they're not common, but they're not rare. There's a fair prevalence in the population. What do you say to someone who's going to look at those numbers and then hear you also say that it will take a really long time to design the types of studies you need? What's the harm of just starting to screen anyway? Why wouldn't we just screen since it's going to take us so long to get an evidence base that would really help answer the questions?
We identify this, the accuracy of screen is one of the gap in the research. For the task force recommended preventive service, we have to see that there's more benefit than harms. Unfortunately, in this case, after review the evidence, we cannot make the conclusion that there's more benefit than harm in this case. And that's why we call informed research. That being said, in the absence of evidence, we encourage the healthcare providers to use their judgment when they decide what to screen lipids for their patient. And the caregivers and parents should bring any concern they have about their children in terms of lipid disorder or any concern about heart disease. And that being said, we do have other evidence-based ways to prevent or help improve her health. For example, the task force has issued a recommendation in 2017. It's a B recommendation. Basically advise that clinicians provide counseling and screening for children 6 years older for obesity and also counseling for smoking for prevent tobacco use. Those will help in the long run improve her health and prevent chronic disease.
For some of these conditions like familial hypercholesterolemia, somebody may know about a family history. Is that something that the task force's recommendations apply to in cases where there is a known family history of dyslipidemia?
So not really. This review statement is focused on the general pediatric population that has no symptoms or known diagnosis of lipid disorder or family history. For those who has known diagnosis or family history of cardiovascular disease or lipid disorder, that's a targeted cascade screening, and which is out of scope of this review. We do not review the targeted screening or secondary hyperlipidemia, which is caused by other disease, and that's out of scope of this review.
Wonderful. Thanks for that clarification. Sometimes it might seem counterintuitive to say that there might be harms of screening. What would be the harm of sending a test? But I think the way the task force thinks about harms of screening, it's really about all of the downstream things that happen after the screen. So, talk us a little bit through, you've talked us through the gaps in evidence, but talk us through what might be a harm that might be a consideration that the task force examined when thinking about this particular recommendation.
We did actually thoroughly review the harms related to the screening and the treatment in this case, but most of the study we reviewed is on short term. It's about 2 years. And although we find that transit increase of liver function or musculoskeletal lab test, we don't know in the long run if we treat the patient at a young age, the longer term harms is still unknown. So that's the reason we do not have sufficient evidence for us to assess the long-term harms. So that's why we think we identify 4 research gaps. One of them is to really study for long-term harms of screening and treatment of the general pediatric population for lipid disorder.
Great. Tell me, I know we're talking about the U.S. Preventive Services Task Force recommendations. There are other bodies that have recommendations in this area, and the task force usually references those. How would you describe those other recommendation statements?
Other organization has recommendation on this topic as well. For example, the AAP, the American Academy of Pediatrics, their Bright Future programs recommend selectively screening children for lipid disorder starting at age 2 for those who has a family history of premature cardiac disease or lipid disorder. And they also recommend a universal screening for those kids for age 9 to 11, again from 17 to 21. And our recommendation is different, but not in opposition to the other organizations' recommendation. It's a call for research in this space. And again, in the absence of evidence, we encourage clinicians use their judgment as whether they should screen or not the patient in front of them, and also care provider and the parents should bring any concern they have to their health professionals.
Wonderful. So that's a great summary and a reminder that I know that the task force has viewed as a part of its role is to really underscore areas where there are research gaps. And you've highlighted so nicely the 4 areas here. And really the issue for children and adolescents, a major area, as you've pointed out, is really understanding the long-term effects of treatments in these areas.
Indeed, actually, there are many evidence-based recommendations from task force, I mentioned 2 already, and also from other organizations in terms of promote health lifestyle and health eating across lifespan. For example, the NHBI has a evidence-based recommendation to assist primary care physician how to address the heart health as well as reduce risk factors across the lifespan of young children. And also USDA and the HHS has recommendation for physical activity as well as diet recommendation for the general American population, including children and young kids. So those are evidence-based intervention strategies can use to promote heart health at young age.
Wonderful. You're a family physician, Dr. Lee. Do you encounter this in your practice? How do you think about making decisions like this for the patients you might see in practice?
Well, indeed, actually, as a family physician, we see a lot of people with hyperlipidemia. For young kids, in particular, when the kids come in, when the parents raise concern about body weight and eating habits, we talk a lot about this as well. When this evidence did tell us whether do or do not screening, we really have to take into account the patient in front of you. One thing I would say, the risk, you have to assess the risk of the patient and decide whether, and also talk with the parents whether to screen the patient. Actually, that's part of life as a family doc and primary care physician. And we're talking about the screening lipid disorder in the general pediatric population. As I said, the evidence at this point does not allow us now to make a formal recommendation, but we're calling for research. That being said, and as a family physician, and we do this on a daily basis. So we have conversation, dialogue with the patient and the family all the time. And I encourage every family physician and healthcare provider to do the same and encourage the care provider bring their concerns and we can provide support for the family and the children.
Nicely said. So this is a call for the researchers to provide more research, but for clinicians and patients, it's really to make the assessments of the patient that's in front of them, to have the conversations for patients to bring their concerns. I'm sure you would say as a family physician to understand the issues of concerns with the whole family, including family history. All those might factor into a decision to understand a lipid profile in a particular patient. But to do this generally across an entire asymptomatic patient population, it really does need more evidence. And it sounds like that's what the task force is calling for.
And as a primary care physician and healthcare provider, we are dealing patient as a whole person. And that's the reason actually we encourage the healthcare provider to engage dialogue, conversation with the family, and really make a decision that use their own judgment when you see a specific patient in front of you. And we're hoping that this recommendation will stimulate more research to help us make a more concrete recommendation on this topic in the future.
Wonderful. Thank you so much for being with me today. I have been speaking with Dr. Lee, a family physician and a member of the U.S. Preventive Services Task Force, about the new task force recommendation on screening for lipid disorders in children and adolescents. Thank you for joining me today.
Thank you for having me.
To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.